Well, hello everybody. It's a great Tuesday. Beautiful, windy. We're blowing away. How does that one thing start with, oh my gosh. Who's the lady that flies, Peggy? Mary Poppins, Wind in the East. Anyways, enough of Mary Poppins. I have her regular heartbeats just thinking of her. Okay, well listen, we're going to pick up again, and this is for your midterm. I'm trying to give you not the actual question, but some ideas to study from. Okay? So that you don't have ectopy, premature beats in your day. That you can get from what? Stress, sepsis. What's sepsis? An infection, okay? Or stimulants. Yeah. All right, guys, let's see what I can pick up here. I'm looking on the midterm.
Hi guys, you guys wanted to see me. Hi.
Yeah, this is Peggy. This is my wife.
I'm the brains behind the
She's the
drama.
brains behind
Yeah.
all this. Okay. So let's see here. Okay, I want you to think about the game that I gave you to play. Okay. Skillstat. And I want you to do that over and over again. It has a learning thing, just a couple things, but then it actually has the game, okay, that you can play. So try to play the game, but look, when you hit on something, forget about the crowds going, oh, ooh, yay. Okay, forget about all that. When you hit on something to get it right, why did you get it right? What is there about that strip that tells you that it's this particular rhythm? That's what I want you to know. All right, let's see here. We're going to be looking at some rhythms in your book, EKG Workout by Jane Huff. And let me see if I go to page 250, which I'd like you to go to too. 250. Yeah, I'd like you to look at, not that this will be on it, but this is an idea. Page 250, strip 9117. So what I want you to do is kind of get an idea of what the rate would be and what the rhythm would be. Now remember those 5 areas that we talked about for identifying strips. And we said that you use them in order when you're identifying a strip. You don't jump around, right? Just reminding you of those again. And go to one here if I can find it. Okay, so does anybody remember what the first thing was? The rhythm. Is it regular or irregular? But I'm going to throw another one in on that same I thought is the atrial rhythm and the ventricular rhythm should be exactly the same. Why? Because the sinoatrial node is causing the shots. That is the pacemaker. So there shouldn't be any difference between the atrial rhythm and the ventricular rhythm, right? If everything is what? Normal. Okay, I found what I want to find here. Does that make sense? Anyways, rhythm analysis, always in order, and you want to use all of these criteria, all 5 of them. Number 1, the regularity of the rhythm. Is it regular or irregular? Both the atrial and the ventricular. Number 2, what's the rate? Remember, if you really want to be obsessive about this, and the rhythm is regular, you can take the number of little blocks between 2 consecutive R waves and divide that number into 1500. So you plug in 1500 first divided by the number of little blocks between two consecutive R's. Or you could do what? The 300, 150, 100, 75, 60, 50. Or you could take the number of cycles. Remember, a cycle is from the point of one wave to the same point of the other. That's one, not two. Okay. So if you could go like from R to R or P to P, that's a cycle. Okay. So you could take, if the rate is really slow, you could take the number of cycles in a 6-second strip and multiply it times 10, right? And that'll give you the rate. Examine the P waves. Do all the P's look alike? What are we talking about now? Their morphology, the way they're shaped, their direction, their size. Do they all look alike? Because they should, if everything's normal. The PR. Remember what normal PR is? 0.12 to 0.20 seconds. Look at the PR. Okay, what's it doing? Is it remaining constant throughout? Is it above 0.20? Or is it within 0.12 to 0.20? Measure the QRS. 0.10 or less is what it should be, right? Okay, in every one of these 5 areas, rhythm, rate, P waves, PR, QRS, should be used in identifying a strip. Right? Like for instance, I just gave you a page to turn to, right? Page 250 in your main textbook, okay? And we're going to give you an example of what we just talked about. And we're talking about what? The strip at the bottom of the page, page 250. Strip 9.117. Okay, so I look at it right away and I can tell you the rhythm is irregular. Okay? The rate's going to be hard to find because of the irregular rhythm. So take a look at that strip, and remember we read EKGs from left to right all the way through. So if I take that R wave and I spray the whole strip with hairnet, I don't need it, but I'm just saying, and I move that first R wave over to line up with that heavy black line at the top. Remember, those are 3-second strip marks. And I go 1, 2, 3, 4, 5, 6, maybe 7. What would the rate be? 70. Okay. I'm sorry. 6 times 7 is 42. Okay. 7 cycles in a 6-second strip. Okay. Let's see what they say it is. 9117. I'm sorry. I must be having really bad coffee days today. If there's 7 cycles in a 6-second strip, okay, and you multiply 7 times 10, yeah, 70. Let's see what they say it is at the back. They're 9.117. Well, these are hard to find. Wow, what a strip to trick us with. Rhythm interpretation, atrial fib, controlled. Now remember, atrial fib is controlled if it's under 100. If it's greater than 100, it's called uncontrolled atrial fib. Okay. So another thing you should know is that, and they say it's hard to measure them because we don't have an atrial rate, right? We only have, why? Because the atrium are what? They're fibrillating, they're shaking. So there is no contraction, there is no atrial kick. Yeah? Okay. So the only rate is an approximate ventricular rate. Okay. And how do we describe atrial fib ventricular rates? Irregularly irregular. It's all over the place, right? Because only an occasional impulse gets through to the ventricles and depolarizes it. All right, so what I was going to tell you is if you're ever checking a pulse and the rhythm is irregular, you want to take it for 1 full minute. Same thing with respirations, 1 full minute. You can't take something on a pulse that's irregular, for 15 seconds and multiply it times 4, or 30 seconds and multiply it times 2, because you don't know where it's going to be in the next thing. So irregular rhythms and pulses that you take and irregular respirations you want to take for 1 full minute. So I was pretty close, huh? You're going, you were? Yeah, I was, because I said if there's 7 cycles, see what I just did? Look, I sprayed this whole thing to play like it was hairspray, so it was real stiff. And I took this and I pulled it over to line up. So that's approximately 7 cycles in a 6-second strip. Times 10, 70. All right, see what else I want to tell you. Remember we talked about 2 types of fib in the heart, atrial and ventricular. Those are the only types of fibrillation, AFib and VFib. And VFib can either be real fine, where it doesn't look like fib, it just looks like you're shaking just a little bit, or it can be coarse. So fine VFib or coarse VFib. Okay, now we talked about a sinus arrest and sinus pause. Real simple. A sinus arrest means the SA node stops, and so you're looking at a rhythm, right? And all of a sudden you get this line. That's a sinus arrest. And then it starts back up again. But if you take calipers and you go on the left side and you're measuring, right? And you go right across that line, right? In a sinus arrest, the rhythm does not pick up again on time. But in a sinus block, well, like this, a sinus node, here's my block, okay? The sinus node is still beating, okay? But the impulses cannot come out of it. Why? It's blocked. Play like this, a brick wall. It's blocked, but it's still beating. So in a sinus block, you do your calipers, you go across that line, you're going to see a line again, like a pause, right? A sinus arrest and sinus block are under one term, pauses, right? In a sinus block, the rhythm is going to pick back up again on time. All right. Paroxysmal means what? Sudden. And we know tachycardia is anything greater than 100. But paroxysmal tach, sudden tach, like in an emergency, yeah? Okay. Paroxysmal tach, sudden, 150 to 250. Paroxysmal flutter, remember flutter, like atrial flutter? Looks like the teeth of a saw. Biggest thing is take the rhythm strip, invert it. Looks like the teeth of a saw. Looks like you got a saw there. Okay, from what? Back-to-back P's, called F waves or flutter waves. 250 to 350 flutter, paroxysmal, sudden. Fib, now you got to listen to how I'm putting this, is hypothetical. Why? Well, how are you going to measure fib? Especially if you look at ventricular fibrillation. No way to measure it unless you get maybe an oscilloscope, some nice machine that takes every impulse. Theoretically, fib is 350 to 450. 350 to 400 250 discharges per minute. That's a lot, okay? But it's hypothetical. You're not getting a pulse. You can't get any pulse if the ventricles are fibrillating, right? Why? Because they're not contracting. Remember, fib is like a bag of worms. There's no contraction, okay? There's no systole. Make sense? Yeah? Okay, so there's no pulses. Let me say that again. I don't know why I'm saying this 2 or 3 times. There's no pulses. All right. Remember what overdrive suppression is. I keep going back to this. Not that there would be a question on it, but what's it mean? It means that the SA node can drive the heart the fastest, so it's in charge. And everybody else what? Is silent. They don't talk. They don't discharge. What's that mean? 3 backups to the SA node if it fails. Atrial ectopic foci. Foci is just like a place. There's a bunch of them throughout the atrium. Any one of them displays automaticity, the ability to contract, and send out electrical impulses on its own between what? 60 to 80. Because what? The SA node sends them out between 60 to 100. So it overdrive suppresses, keeps all the other backup pacemakers quiet. But an atrial ectopic focus can fire from 60 to 80. So if the SA fails, atrial is a redundancy pacemaker, it can take over automatically, automaticity, automatically, the beating and the pacing of the heart. If the sinoatrial node fails and an atrial fails, a junctional can pop up and take over between 40 to 60 beats per minute. If you're having a really bad day here in Atalanta or we're at, SA fails, atrial fails, junctional fails, last hope, ventricular ectopic focus can take over from 20 to 40, right? But any ectopic focus can become irritable in fire. The ventricles with lack of oxygen. Anytime you lack oxygen, obstructed airway, okay, your airways are closing off. Why don't we give an EpiPen to somebody? Because they're allergic to something, like a bee sting, like cookies. A guy come in here one night, peanut butter cookies. I thought, oh, I'll take them. But it's not funny. Why? Because those substances that an individual is allergic to causes constriction of the bronchi, okay? The major airways. So they constrict. So what does Epi do? Epi locks in a beta 2. It's like a lock. We name the locks. Beta 2. Remember, a drug is a key. What's a key lock into? A lock. The lock is a cell surface receptor site. On the bronchi, you have beta 2. Epinephrine locks into beta 2, EpiPen, epinephrine, cell surface receptor sites, and dilates the bronchi, opens them up. Okay. By the way, how many EpiPens do we normally give somebody? 2. You know why I'm telling you this? Because maybe this is you, I don't know. But I called a person in my family once because I know she's allergic to almost anything. And the doctor prescribed EpiPens. And I said, so let me ask you a question. I said, where are they? Well, I keep one in my purse. Mm-hmm. And I keep one at home. Excuse me? One at home? What's that for? Well, in case my purse is not close by, I go, look. After giving the first injection of epinephrine, within 5 minutes or more, you may have to give a second injection. That first may not have worked. You need them both with you at all times. All times. Hello. It's okay. I've done more ridiculous things. Okay, cardiac arrest. And I just mentioned a couple of types. What if you get P waves, right? Long lines between them. What are you going to do? Tell me, yeah, the P's, the morphology looks very similar, Mr. White. They're coming from the same focus, the same site. What's the rate? What do you care? If all you see is P waves, it's cardiac standstill, which means what? There's no ventricular contraction. There's no QRSs. Hello. Okay, so don't tell me about morphology and stuff. They're in cardiac standstill. What about VFib? So cardiac standstill is a type of cardiac arrest. VFib is a type of cardiac arrest. And I know I got this wrong, and thanks for telling me. I'll correct it. And yes, you will get your point. PEA, pulseless electrical activity. Remember, I told you this over and over again. Do not treat a monitor, treat a patient. Do not treat a monitor, treat a patient. So if you go in and the guy's got a rhythm, don't go, well, he looks okay. Yeah, he's in a rhythm, maybe something similar to sinus, and what's he doing hanging over the side of the bed and his lips are blue and stuff's running out of his mouth? Hello? You treat a patient. Mr. White, are you okay? Hello? Sir, can you hear me? You okay? A little sternal rub there. Hello? Okay. Don't just look at a monitor and start run for things. Okay. Or say everything's okay. The guy looks like he's in fib. What, do you go get the defibrillator? No. Why? Because maybe he disconnected a couple of leads and it looks like fib. Don't treat a monitor, treat a patient. Make your evaluation quick, but treat a patient. Okay, we're gonna talk about maybe blocks. There's three major categories of blocks that I want you to know. First, second, and third degree. First, second, and third degree. And when you look at a rhythm strip, I don't want you to know pages of data. I want you to be able to look at them and go, that's a first degree. First degree, I'll give you a real simple thing to kind of know it when you see it. NSR, normal sinus rhythm, consistent, prolonged PR. What does that mean? The PR, remember, 0.12 to 0.20, but this is above 0.20. So maybe it's 0.24. So it looks like you're looking at NSR, normal sinus rhythm. The only thing that's wrong, remember, PR is one of the things we use to evaluate a rhythm strip. If the PR is 0.24 here, it's going to be 0.24 here, it's going to be 0.24. Wherever you see the PR greater than 0.20, and it looks like a normal sinus rhythm, you've got a first degree AV block. Second degree AV block has two subtypes, Mobitz 1 and Mobitz 2. Mobitz 1, real easy to recognize. Remember another thing we evaluate a strip with? PR, interval. Okay. In a Mobitz 1, the PR lengthens. It gets longer and longer and longer every complex you look at. The PR lengthens from cycle to cycle to cycle. Let me say it again. The PR lengthens from cycle to cycle to cycle. It keeps getting longer. Punctual P, drop QRS. Punctual P, drop QRS. That's a Mobitz 1. Also called Winky-Bach. And it usually repeats itself, called Winky-Bach footprint. Mobitz 2. Again, a type of second degree AV block, atrioventricular block. Mobitz 2, you have 2, 3, or 4 P waves prior to every QRS. The PR of the conducted beat remains constant. So if I don't know, hopefully you can see this, but I'm just going to hold this up. Great example, big. Can you see that rhythm? Right here. Okay. What's odd about this? Two P waves before the QRS. Two P waves before the QRS. What did I just say? Talking about a Mobitz 2, 3, or 4 P waves prior to every QRS. The PR of the conducted beat, this is a conducted beat. There's no conducted beat here. The P followed by the QRS is a conducted beat. The PR of the conducted beat remains what? Constant. It's the same, no matter where you look at it. So if you have 2, 3, or 4 P waves prior to every QRS, and the PR of the conducted beat remains constant, you got a Mobitz 2. Third degree. Now, the bad thing about a Mobitz 2 is it can deteriorate into third degree with little or no warning, or the heart could stop with Mobitz 2. So you just don't want to let this go. Okay? Third degree, called a complete heart block. None of the impulses from the SA node are making it through the normal conduction system to the ventricles. None. So guess what happens? The SA node paces the atrium. The SA node paces the atrium, the upper chambers. Usually either a junctional or ventricular ectopic focus paces the ventricles. Uh-oh, you got two pacemakers, independent of each other. Problem with the third degree is the ventricular rate drops way, way down. So the guy may feel a little dizzy, may go into a syncopal episode, syncope, S-Y-N-C-O-P-E, fainting, they pass out. Okay? Why? They're not getting enough perfusion. Perfusion, the flow of blood. To what? The cerebrum, the brain. So they pass out. Okay? Not all the time, but they can. The other problem with third degree is, so the rate is way too slow. A lot of times to support life, so guess what we do? We put them on a pacemaker. Okay. And the other thing that's wrong with this is it can deteriorate with little or no warning. Third degree, also called a complete heart block, into cardiac standstill. Okay. All right, I'm looking. Remember the three eyes? The three eyes, like India. Ischemia is a temporary lack of blood to the heart, also called angina pectoris. Angina, pain. Angina, pain. Pectoris, chest pain. Okay. But if you don't treat it, guess what? You go into what? Injury. An injury is like starting to get damage to the cells. Okay. Sorry about my big clock in the background. Okay. If you don't treat that, you go into infarct. What's infarct? Death. And where does all this start? All this starts on the inside of the heart, endocardium. Progresses through the myocardium, progresses through the pericardium. So it goes through all the layers or walls of the heart. And if it does, it's called trans, which means through, mural, which is like a wall. Okay. So the thing of it is, you want to try to treat these without waiting. A lot of guys, ladies, big macho people like myself, right? Just go, I don't want to go in. Sit around the ER, look at dead goldfish, read outdated magazines, whatever, you know. And especially today, probably people go, I don't want to go in. Guys, if you start getting this, what's one of the things I told you to administer if the patient has had it prescribed? Usually we prescribe nitroglycerin, sublingual. Lingual is tongue, sub, under. A little tiny tablet, place it under the tongue, and we let it dissolve. And what's it do? Nitroglycerin is a vasodilator. It opens up what? The coronary arteries that lie over the heart that feed the heart itself with blood and oxygen. Problem is, coronary arteries kind of around the outside. And you're trying to get blood from the outside, the coronary, to the inner aspects of the heart. If the chest pain doesn't go away within 3 to 5 minutes, you give a second nitro. If the chest pain doesn't go away, you give a third nitro. Now, don't keep giving nitro. If you've given 2 or 3 nitroglycerin and honestly don't see any improvement, I would get 911 on the phone and don't transport. What are you going to do? If the patient passes out in the car and you got to do CPR, what are you going to do CPR and drive at the same time? No. Okay. Don't place yourself and the patient in a position where you act like, I have. Belly the ambulance, drive somebody to ER. And I told you what happened. We're a block from ER. And they told me they were having, arrhythmias. And I said, well, I'm going to call 911. Oh, no, I don't want you to call 911. So I just went over there and got him. Bad move on my part. Bad move. Don't do that kind of stuff. Now, I'm not saying 100% of the time, but let's just say this, 99.9%. Yeah, I wouldn't. Again, for the second or third time that I've done it, watch. Give the nitro. Still get pain and pressure, call 911. And by the way, when you give them the nitro, the best thing to do is sit them up a little bit. Okay? Why? Because a lot of times with a heart attack, what do you get? Shortness of breath. What are the symptoms? Shortness of breath. Chest pain. The pain can radiate. Predominantly, it moves down the left arm all the way into the fingertips. Okay? The pain can move up to your jaw. You know how many people I picked up in ambulance in a dental office because they thought they were having problems with their teeth when they were actually having a heart attack? Shortness of breath, dyspnea, D-Y-S-P-N-E-A, dys, difficult, labored, abnormal, pnea in this case, breathing. We had one guy who's laying flat, EMTs brought him in, I'm having difficulty breathing. Pulled the gurney up like this, oh, I can breathe better, see? It's a miracle, we saved. Set him up. Denial, expected. Want me to call 911? Don't ask the patient that, just do it. Okay, they're going to tell you no, it's the peanut butter and jelly sandwich I had at Denny's. No, it isn't. Okay. Another symptom, indigestion, upset stomach, nausea. John Doyle years ago told me about a guy, patient, they came all the way from Vegas. Now, all the way from Vegas, he was popping Rolaids. Just eating them by the handfuls. My stepdad used to do this. Get in the car. I think he even used to pass them out on Halloween. Trick or treat, Rolade, whatever. All right, so here it is. A lot of people with indigestion and gastrointestinal problems. Okay. Oh, by the way, that was I requested some PowerPoints for a book that I've used since 1986 for medical terminology. And by the way, if you want to go get a job in the hospitals and so forth, they're giving, a lot of people tell me they're giving medical term tests. So might not be a bad idea to take medical term, and I'm teaching it this next semester, okay, on 2 different days, okay, but it's going to be online, medical term. And it's a great class. I've enjoyed it. I mean, when I first started teaching medical term, I thought, medical term. I'm a registered nurse. I've taken microbiology, biochemistry, organic chemistry. I've taken all these courses. This would be a piece of cake. I started looking at the book and I went, what? What is this word? There's a lot to know. Okay. So medical terminology is a good thing. One of my students went down, they tried to get a job at one of the local doctor's offices in town, and she said, okay, so have you had medical term? Yes, I have. Okay. And I'm trying to think. She said, well, our surgeon here, our doctor, does things like cholecystectomies. The girl kind of looked and she goes, so girl was interviewing, so what a cholecystectomy was and is, right? And the girl goes, yeah, yeah, that's removing the colon. It's close. It's the gallbladder. Okay. So who knows what they're going to ask you during the interview? Be prepared. One of my students, just throwing this out there, one of my students went in to get a job as a phlebotomist, and I, have taught state certified phlebotomy for years. And I took one girl up, which I usually don't do, but I took her up to the lab and I said, if I were you, I'd hire her. She's this good, you know. So guess what? The head of the lab said, let me ask you a question. Have you had medical term? No. And I didn't know he was going to ask that. Have you had billing and coding? That's another big thing. Heidi Shaw for Victor Valley College teaches billing and coding. Great teacher, great professor. Take the course, okay? Because they want to get paid, right? So I've had billing and coding, and then I've got this and this and this. Makes you look better. Okay. Now, okay, you're looking at EKG, right? You're looking at waves, PQRST, right? What makes the diagnosis, maybe you remember, of infarct? Remember STEMI, S-T-E-M-I, ST segment, elevation, myocardial infarction. The ST segment, where should it be? At the baseline, right on the isoelectric line. Should not be above it. That's elevated. Should not be below it. That's depressed. Okay. If the ST segment is elevated, it says we've got a heart attack going on right now, as opposed what? To the ST segment at the baseline. Now, what's the other one? A Q wave. What kind of a Q? A significant Q. What is a significant Q? Not that you would need to know it, but what is a significant Q? Significant Q is approximately one third, I'm just doing this to play like it's a third, the entire height and depth of the QRS complex. If it's one third the height and depth of the QRS complex, it's a significant Q, or one little block wide or wider. So if it's one little block wide or wider, or one third the height and depth of the entire QRS complex, talking about a Q wave, is a significant Q. Now, why would they have to know, just asking, whether it is an MI that's occurring right now or one that's occurred 5 years ago? Because 5 years ago, we really can't do that much for it, can we? No. But if it's occurring right now, it's elevated, ST segment elevation, myocardial infarction, we can do some things maybe. Okay. All right. If the ST segment is depressed, it shows a subendocardial infarct, which means what? It's just starting to appear. Okay. You could also get depression from digoxin. I'm looking. What chamber of the heart does MIs mostly revolve around? The left ventricle. Why is that? Because the left ventricle, when it contracts, forces out all of the oxygenated blood to all the cells, tissues, and organs of the entire body. Okay? And what do we call that? Systemic circulation. All right, I'm looking. Remember, leads are like cameras. They show us different aspects of the surfaces of the heart. V1 through V4, anterior. V1 and V2, right side of the heart. V5 and V6, left side of the heart. 2, 3, AVF, bottom portion, inferior portion of the heart. 1, lead 1, AVL, augmented voltage left arm. V5 and V6, left lateral aspect of the heart. 1, AVL, V5 and V6, left lateral. What's I stand for? V and R, idioventricular rhythm. What's that mean? A rhythm that is predominantly associated with this particular thing that we're talking about, IVR, idioventricular rhythm, which is what? Usually 20 to 40, but remember, a ventricular focus can go above 40 all the way up to 100. What do we call that? Accelerated IVR. Recall, a junctional focus can go above 60, 40 to 60. Above 60 all the way up to 100. What do we call that? Accelerated junctional. 3 types, 3 areas that you're going to find cells in the heart. Polarized. Negative interior, positive surface. What's it doing? Nothing, it's resting. Depolarized. Positive charges go into the cell, negative charges come out. What happens when it depolarizes? It contracts. Repolarized. It goes from contraction back to resting. R and R prime, 2 mountain peaks. Let me see if I can mark something up if I haven't done enough. Here. So you're looking at a really wide QRS. Okay. Let's play like this. Inverted V here is a QRS, right? And then right next to it, I'm going to draw another one. Notice what I've done. Here's one QRS, here's the other. What do I have two? Because you have something called BBB, or bundle branch block. Now watch what I'm going to do now. I'm going to erase everything in the center here. And what am I left with? The 2 mountain peaks. The first mountain peak we call R. The second mountain peak we call R prime. An R with a little dash. So this is R prime. When I have a bundle branch block, something is blocking one of the bundles, either the right or the left bundle branch. So it'll look like you have this notch, QRS, yeah. The first peak of the first notch is called R. R is the ventricle that fires first. R prime is the ventricle that's delayed that fires last. Okay? And that's a bundle branch block. And a bundle branch block, we measured from, look, here, yeah, to right here, to the very end of it, is wide. What's normal QRS? 0.10 or less. This can be like 0.12 or greater, the bottom of this, yeah. All right. Still thinking, still moving forward. Okay, hypertrophy. Hypertrophy is a word that looks like hypertrophy. 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 But it's pronounced hypertrophy. Hypertrophy. It means enlargement. If you get hypertrophy of the heart, it's enlargement of the heart. Okay? Enlargement of a chamber of the heart. You go, well, that's good. What's good? Hypertrophy? No, it's not. You go, why? Because you got more there to pump. No. The larger a heart gets, the more ineffective as a pump it is. Okay. So, looking at the questions here. If it's in an atrium, kind of do it like this, just don't show this to anybody. If you get hypertrophy of an atrium, you know what you get? You get something that looks like this. And I have to explain this. So look, play like this a P wave, yeah? And notice if we drew a straight line, this P wave goes above the isoelectric line and below it. So guess what it's called? Diphasic P wave. Di, meaning two, di, phasic, P-H-A-S-I-C, phasic. The reason I drew the P wave like this is because it has two parts. It has an initial component, the first bump above the baseline, and it has a terminal component below the baseline. Yeah. If the first bump is bigger than the second bump, it's right atrial hypertrophy. If the second bump is bigger than the initial bump, it's left atrial hypertrophy. Okay. Now you go, well, how am I going to see that? Because you're going to see a P that looks like this. Yeah, diphasic. Once again, notice this first part is pretty small, the second part is pretty large. So what would the second part be? Left atrial hypertrophy. If this were bigger, it would be right atrial hypertrophy. Hypertrophy of the atrium is real simple. It's a diphasic P wave. The first part is called the initial phase. The last part is called the terminal phase. The question is, which part is bigger or longer? And we're also going to talk about this statement that I've given you multiple times, and that is, as positive charges move towards a positive skin electrode, there is a positive upward deflection on the EKG. If it moves away from the positive skin electrode, there is a downward or negative deflection on the EKG. Well, let me ask you. If we were to look at the QRS in the chest leads, the V leads, V1 through V6, and we were to go to V1, remember I said V1 and V2 are? On the right side of the chest. How is the positive waves moving out of the SA node? Downward and to the left, not upward and to the right. Okay, because V1's over the right, yeah. So if the positive charges are moving away from V1, V1 should be what? Should it be mostly above the baseline or below it? Above, no, below. V1 should be normally negative. Unless there's something pathological going on, and we'll talk about that as we get to it. Okay, now remember we talked about the P wave and the T wave, if you get real fast rates, can go together, right? And what's that called? Called a TP wave, right? So you don't know whether there's a P in there hiding in the T, but there could be, called a TP wave. I want you to play with skill stat over and over again. I want you to get used to sinus rhythms, atrial rhythms, junctional rhythms, and ventricular rhythms, how they look. Okay. Now I also want you to look up, not only atrial hypertrophy, remember diphasic P's, initial component, terminal component, yeah. I want you to look up things like, what if you had right ventricular hypertrophy or left ventricular hypertrophy? See, one of the things that can cause this is hypertension. And millions of people have hypertension. Children have hypertension. Next time you're in a drugstore or something that you can relax for a little bit, it wouldn't be today, but check your blood pressure. Now, does it look normal? Or, I mean, what did I say normal was? 120/80. That's normal blood pressure. What if you're hypertensive? That starts at 140/90. If you hit a systolic of 140 or a diastolic of 90, you're there. Don't tell me it's borderline. Again, that's like being borderline pregnant. No, you're hypertensive. And you don't have to be both. You could be one or the other or both. The 140 goes up to 159. And the 90 goes up to 99. So you got a little bit of play there. And they call that 140 to 159 for a top number and 90 to 99 for a bottom number. First stage hypertension. First stage. You go, what's second stage? 160 or above and 100 or above. Okay. And having hypertension causes stress on your heart, causes your heart to work harder. Hypertrophy. And getting hypertrophy makes your cardiac output not go up, but go down. Now, let's see here. Okay, remember I said V1, normally speaking, when you look at it? V1 is on what side heart? V1 and V2? Right side, right? So are the positive charges coming out of the SA node going towards it or away from it? They're going away. So V1 should be positive or negative? Negative, mostly negative. Okay. But with right ventricular hypertrophy, there's a large R wave in V1. That shouldn't happen. V1 should be mostly negative. If there's a large R wave, that can mean right ventricular hypertrophy. Okay? Now, what's odd about that is you go from V1 to V6, the R wave gets smaller and smaller and smaller. Okay? Left ventricular hypertrophy, where there's a very thick wall in the left. A good way to do this is look at V1 and V5 for left ventricular hypertrophy, also called LVH. Look at V1 and V5. V1 should have a negative wave, mostly below the baseline, okay, negative QRS, and V5 might have a high QRS. And you go, well, isn't that kind of, normal? Well, it is, except when you add them together. Remember when we go vertical on an EKG? Millimeters. So vertical, okay, shows amplitude or voltage. Amplitude is the height or depth of a wave. If you add how many millimeters, remember each little block is 1 millimeter high and 1 millimeter wide, so we're going vertical. If you add the depth of the S wave in V1 to the height of the R wave in V5, if it's greater than 35 millimeters, you have probably left ventricular hypertrophy. Okay? I'm looking, making sure I give you all the hints I can on this test. Just so you know, CPR in and of itself does not save a lot of people. You go, well, what's the point? It's CPR combined with other modalities. Like what? Like the AED, the automated external defibrillator. For every minute that you don't defibrillate, the chances of survival decrease by 10%. I can't tell you how many CPR things I've done because I worked ambulance and I worked emergency room. Guess how many people we saved? Very few. Why? In 10 minutes, the game's probably just about over. Unless you have other factors working in, like core body temperature. If your core body temperature is way down, then the damage to the brain cells starts going down like this, yeah, and you have more time. You always give the victim the benefit of the doubt, though. You always try. I remember, if you've seen this movie, it's a great movie, about Kevin Costner and the Coast Guard training these guys. And so one day he's supposed to lecture on hypothermia. He's supposed to tell them the effects. You know, he does. Gets a bunch of ice, throws on a big tub, and has everybody jump in. And they're sitting there shaking like this. And the captain comes out and he goes, "You were supposed to lecture on this." He goes, "Yes, I was." In about 2 minutes, they'll understand. And then another guy's over there on the side doing compressions on a mannequin because he was supposed to like rescue him from the water. And he finally stops and he goes, "Why'd you stop?" "Well, I didn't think he had a chance." He goes, "Are you a coroner?" He goes, "We never stop. We never stop." I mean, we do, but you understand what I'm saying? We always give the victim the benefit of the doubt. I knew a guy that was playing around with some other kids. He's a kid himself, and he took a rope, threw it over a tree up here in the high desert, and he put it around his neck, goes, "Look, I'm hanging." And finally he slept, and he was hanging. And the temperature is about 110, 115 degrees out there. Guess what? He survived. So did the guy I told you about, the kid under ice water. A bunch of other kids threw out a dead squirrel, kind of like a frisbee, onto the ice. They dared him to go out. He was underwater for 30 minutes. Now, I scuba dive on occasion. Not much anymore of it. Scuba dive, yeah. If I'm underwater for 30 minutes without air, I'm dead. Core body temperature goes down. This kid walked before a group of microphones about 4 days later and said, "Thank you, Merry Christmas," and walked out of the hospital. We always give the benefit of the doubt to the victim. All right, guys. Skill stat. Work on that. Work on these rhythms. Start filling them in. See if you can identify why they are like they are. Okay. I mean, why do they look this way? Just because the book tells you have the right answer, don't go, "Yeah, I must have the right answer because the book said so." No, you're not going to have the book in the ER. Rhythm. Every strip you see, rhythm. Is it regular or irregular? Rate. What's the rate? P waves. Remember, what if you don't have any P waves? And you see normal QRSs? Well, it sounds junctional to me. Why? Because the junctional fires off inverted P waves. Not upright P waves, inverted. Okay. PR. Remember the first degree AV block? We kind of figured that out because of the PR is greater than 0.20. Remember Mubitz 1, the PR lengthens from cycle to cycle to cycle, punctual P drop QRS. I'm going to tell you one point you're going to get confused in. A Winky Bach and a third degree. Because if you look at some segments of the third degree, it's going to look like the PR is getting longer, but then it's getting shorter. In a third degree, the P's and the PR interval has nothing to do with the QRSs. The P's appear to walk right through the QRSs and walk out the other side. Okay. So don't get Winky Bach. PR lengthens cycle to cycle to cycle, punctual P drop QRS. and third degree, where there's two independent pacemakers, where the P and the PRs have nothing to do with the QRSs, mixed up. Determine rhythm, determine rate, examine the P wave, measure the PR, measure the QRS. What if you got a QRS that's a 0.12 or greater? Well, maybe, we just told you a couple of moments ago, maybe you have a bundle branch block. Maybe. Okay, if you have R and R prime, those little peaks. Okay, if the R and R prime is in V1 or V2, it's a right bundle branch block. If it's in V5 or V6, it's a left bundle branch block. Now I have one more thing to say. I read something last night, some kind of email from somewhere, and it said something, I mean, it was all over the place, but whatever. And it was back before a class began, and it was something in reference to me, and I was just going, what? I don't even get what they're trying to say. Listen, if I ever say something that sounds condescending, that sounds like I'm not lifting you up, or I don't care, can you call me and let me know? Because I'd like to apologize. I mean, sometimes I say things or I do something with my eyes or something, and people maybe take it wrong. No, 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 no. I care about your progress. I care about your success. That's what I'm for. Guys, God bless. Have a nice afternoon. Be safe out there. And by the way, if you didn't hear, the president of the college, Victor Valley College, said we will still wear masks at the college. Which I don't know where they're going with all this, taking up all the restrictions and things like that. I mean, I can understand it a little bit, but honestly, I don't get it. What do you think? The virus changed overnight? This stuff is deadly, guys. Personal protective equipment. You need to use a little bit of this stuff. You need to think. Try not to touch your eyes, your nose, your mouth, and things like that with your hands, especially after being in things like the stores and so forth. Stay the 6 feet away. All right. God bless. Got any questions? Call me. All right. Good luck with this midterm on the 20th. We have Wednesday evening at 6 p.m. Okay, a Zoom. Tune in. I want to hear from everybody. I do. If I don't hear from you, I'm assuming that I don't know what I'm assuming. Okay. Call me. Let me know that you're still there. I just don't see a name on Zoom and you don't say anything. Okay, remember, I told you this in the first day. Part of this is participation. Giving me your ideas. I want to hear them. All right. Guys, God bless. Have a nice day.